All right. I think we're ready now for part two of this lecture on pediatric respiratory diseases. Once again, let me share my screen with you. So part two is really dedicated to the diseases of the upper and lower respiratory tracts. We'll talk specifically what I was asked to cover. We'll talk on croup, epiglottitis, viral bronchiolitis, and asthma. And at the end, I've included several clinical vignettes that will hopefully be board style and help kind of cement the learning for this lecture. So let's jump into it. Let's talk first about uh, croup, acute laryngotracheitis. You may hear it called in some textbooks and some references laryngotracheobronchitis. I think that's a fine term to use as well. Probably somewhat inaccurate. I'm not sure many of us think of croup as affecting as far down as the bronchus, but perhaps it does. What we know, clinically, its most notable effect is at the level just below the vocal cords, well, just above and just below the vocal cords, so the larynx, and then the most proximal portion of the trachea. This is a very common infection in the pediatric world. Classically, we think of parainfluenza type 1 and 2 as the viruses that often lead to this disease state. But over there on the bottom right screen, you'll see several different viruses that can cause croup. So be on the lookout for paraflu in the clinical vignette on croup, but several viruses in the real world can cause it. Who does it affect? Toddlers in general, infants and toddlers, so anywhere generally speaking from 3 months to 3 years. It's very common. Up to 15% of children are impacted. What actually happens to cause the disease state and the signs, symptoms, and clinical picture we see with croup: viral inflammation leading to swelling, the larynx and the proximal portion of the trachea or the subglottic area. This area is around the level of the cricoid cartilage. Remember from part one, we talked about most people will tell you. Now, this is somewhat debated. It's not capital T truth, but I think it is relatively true in the pediatric world that we believe the narrowest portion of the pediatric airway to be the cricoid cartilage just below the vocal cords. So you can imagine this airway, this portion of the airway gets swollen. That will lead to significant airway resistance. Remember Odom's law and Poiseuille's law that we talked about in part one. Significant airway restriction, airway obstruction, and increased airway resistance, ultimately obstructing flow of air into the airway. And what happens is in that scenario is the classic finding of stridor, or this high-pitched inspiratory sound. Because of the high airway resistance, airflow moves from being laminar to turbulent as well. And so as a result of that, we see those signs of respiratory distress that we talked about at the end of part one. Let's look at a video with some audio here of a child with croup. There you go. You'll hear on inspiration, stridor, right there. And then you also notice the barking cough as well. That's pretty pathognomonic and classic for croup. A seal-like cough or a barking cough is the terminology that you'll typically hear, and even parents will use that terminology. So important to kind of keep that in your memory bank. The natural progression of croup, typically upper respiratory symptoms are initially noted with some cough, congestion, rhinorrhea. From there, within the first couple of days of illness, children will oftentimes develop fever. They'll develop that barky or croupy or seal-like cough. They'll develop stridor, and then their voice if they're of speaking age, may sound hoarse as well, because of difficulty handling secretions, as the portion of the airway above the level of the cords is swollen. They may have difficulty handling and swallowing their secretions, and so drooling may be prominent. But in general, these children are pretty non-toxic in appearance compared to another disease that is important to distinguish croup from, and that's bacterial tracheitis, where those children appear very, very acutely ill and toxic. And these children are able to move from a supine position to an upright position to a prone position, and generally maintain adequate respiratory status, adequate airflow. Click forward here. Okay. And then treatment for croup. Really supportive care is the name of the game here. And it kind of depends on the setting that you're in. If you're in the outpatient setting, if you're the general pediatrician seeing the child with croup, there's going to be some very basic things that you can recommend parents do at home to make sure the child stays adequately hydrated. You may recommend to them to sit with their child in a bathroom with kind of steamy air from the shower. The steamy air is able to sort of bypass the level of obstruction in the upper airway easier than normal air, or at least that's the prevailing thought behind that. Treat fever, or maybe even give antipyretics prophylactically, things like Tylenol and ibuprofen, to prevent fever, because children look much more ill when they're febrile than they do when they are afebrile. Consoling and comfort, preventing the child from becoming agitated if you can, because they'll also look worse when they're agitated. If you're seeing this child in the emergency department, or if they're admitted to the hospital floor, giving them supplemental oxygen as needed to maintain their saturations. And then in some cases, the work of breathing becomes so severe, the airway resistance is such that you'll need to take further measures and escalate respiratory support to help with their work of breathing. So things like non-invasive positive pressure ventilation, heliox, moderate sedation. In some severe circumstances, intubation may be warranted as well. Other things in the emergency department or in the clinic that you could use to help reduce inflammation in the emergency department. Racemic epinephrine is an inhaled nebulized treatment that causes local vasoconstriction within the airway and can help reduce swelling. Dexamethasone can be given either in the clinic or the pediatric emergency department as well, and that may help prevent hospital stay. So something to try and keep in your toolkit. Consider an ENT evaluation if the child is admitted, or if there are multiple presentations to the emergency room for stridor. Also consider if the patient requires intubation for the severity of this illness. It's worthwhile for an ENT to take a look at the airway and see if there isn't something else going on, some sort of airway anomaly that maybe croup has kind of set in and really made this airway anomaly truly present itself, or maybe croup was a misdiagnosis and there's actually something else going on that we need to know about and identify. So that's croup. On to the next entity that I wanted to cover. That's acute bacterial epiglottitis. This is simply put inflammation of the epiglottis. Thank goodness this is a disease entity. I'm going to knock on wood now as I'm currently on call while I'm making this video. This is a disease entity we don't typically see much anymore in the pediatric world in the era of vaccinations. I have never seen this. I've been in pediatrics for 6 years and I've never seen this, but it is certainly still possible, especially as vaccination compliance is kind of dwindling in recent years. Traditionally, and for your boards, know the association of bacterial epiglottitis and Haemophilus influenza type B. Others are subtypes of Haemophilus influenza, non-typable, that can cause different diseases in pediatrics, but typically they do not cause epiglottitis. So historically speaking, and at least classically for your boards, Haemophilus influenza type B is what you should think of if you're presented with a vignette on bacterial epiglottitis. Treatments for this, steroids and antibiotics, because Haemophilus influenza is a bacteria. These children are going to be very toxic in appearance. They'll have signs, symptoms of a respiratory obstruction, so stridor, increased work of breathing because of high airway resistance. These kids may sit sort of in a tripod position, leaning forward with their arms, palms flat on the bed, trying to catch their breath, trying to get air in. The key here is to just try to limit bothering the child. Anything like an IV poke or any sort of anxiety-producing stimulation can really tip these kiddos over the edge from compensating, although severely ill, to no longer compensating, no longer moving air in, and having a cardiopulmonary collapse. And so keeping them comfortable is key here. Say the kid does completely obstruct their airway and they're no longer able to move air, and as such they are on the verge of cardiac arrest. It's important to very quickly secure their airway. Make sure the person intubating the child is the most experienced in the room. Make sure that ENT and anesthesia have been called. Ideally, they're the first up to intubate, but they may not be there if this is happening in the middle of the night, and none of these specialists are in-house. So whoever the most experienced airway person is, and then use all your resources. Use video laryngoscopy. Have all your resources at the disposal there at the bedside if you can. Notice the picture here at the bottom, what that beefy red enlarged swollen epiglottis looks like in bacterial epiglottitis. That is why you need your most experienced person handling the airway, because it will be a very difficult intubation. There is a pretty high mortality rate on the international level. Again, we don't typically see this in the United States anymore, and I hope to not see a return of it, as vaccination is not as high of compliance as it used to be. Some other differentials that you may consider when you are confronted with a disease like this that you think is epiglottitis. Consider bacterial tracheitis. That's a bacterial infection of the trachea just below the level of the vocal cord. Typically, those children are very ill, but maybe not as toxic as one with epiglottitis because their airflow is not quite as obstructed. You may consider a retropharyngeal abscess, a peritonsillar abscess. You may consider a diphtheria and the classic pseudomembrane, very rare disease entity in the United States. I have not encountered that. Here is a lateral cervical X-ray taken of someone with epiglottitis. On the left side, you'll notice the positive thumbprint sign compared to the normal on the right side. I just want you to kind of tuck this away in your memory bank. This may be something that is presented in a clinical vignette to sort of like tee you off to this diagnosis. So the thumbprint sign on lateral cervical X-ray is consistent with epiglottitis. Let's move next to viral bronchiolitis. Very, very important disease entity in the world of pediatrics. Bronchiolitis affects young children, newborns, infants, toddlers up to the age of 2 years, traditionally speaking. This disease occurs in young children for a variety of reasons, but suffice it to say that the airway is smaller, the bronchioles are smaller. This disease impacts particularly the terminal bronchioles, causing edema at that level. And because these ruptures are already relatively small in young children, that increase in resistance, that reduction in the radius of the airway will tip these children over into pretty profound disease and respiratory distress, in many cases respiratory failure. It's a very, very common cause of hospitalization in infants. The statistic I found actually showed that it's the most common cause. So something you guys definitely need to be aware of and to be familiar with. Signs and early symptoms of bronchiolitis that is evolving. It may begin with kind of a mild URI in the initial few days. Nasal congestion, rhinorrhea, cough, low-grade fevers, maybe the early signs and symptoms of this illness. And then over the days to follow, as the virus really moves from upper respiratory to the lower respiratory tract, signs of respiratory distress become more and more prominent and may land the child in the emergency department on the hospital floor, or even in my realm in the pediatric ICU due to pediatric respiratory insufficiency or impending respiratory failure. This is a virus, and so typically the mainstay of treatment ultimately is the tincture of time, as is in many cases in the world of pediatrics. But by the time they reach the hospital floor or the pediatric ICU, there are some therapies we'll talk about in the next slide that we need to consider to help them through it. Lastly, I just want to talk about the viruses associated with bronchiolitis. As with Croup, many viruses that can be implicated, but the top one that I want you to remember from this lecture is RSV, or respiratory syncytial virus. Very nasty player in the world of pediatrics, and something that we deal with quite a bit in our realm. Is known to cause a pretty virulent and severe course of bronchiolitis. I don't want to spend too much time here on this slide, something that you can peruse when you're studying this material later. But traditionally speaking, we think of bronchiolitis as being a seasonal disease. I did my residency in the state of Florida, and there really we saw RSV and bronchiolitis year round. Historically speaking, in the states north of Florida, it follows more of a winter pattern, like you think of with influenza for adults. I will tell you that's sort of out of the window. That sort of concept is out the window now in the era of COVID. For some reason, there will be an epidemiologist who makes their career on solving this puzzle, but we're seeing RSV much earlier in the year than we used to see it. June, July, August, we're seeing a lot more RSV in places like Kentucky, where we are now, of course, and North Carolina, where I did my fellowship training, seeing it much sooner than we used to, not just the winter months anymore. We really talked about kind of the natural progression here of bronchiolitis, and so I'll skip over those points in this slide. Make special note here of the children who are at risk for severe bronchiolitis. Certainly prematurity, congenital heart disease, neuromuscular disease or neuromuscular weakness, things like trisomy 21, for example. Children with immunodeficiency, children with known airway anomalies, and then young infants less than 2 months of age. They're all at risk for a severe course of bronchiolitis. But I will tell you, there are plenty of children that I've taken care of that were perfectly healthy until 9 months of age, and they got RSV and landed them in the ICU. So perfectly healthy children can get bronchiolitis and suffer respiratory failure from it. The pathogenesis of bronchiolitis we talked about just very briefly. It involves viral targeting of the terminal bronchiolar cells, causing damage and inflammation of those cells. You have edema of the terminal bronchioles, and you have mucus excretion into those portions of the airway as well. All of these lead to obstruction of the airway, poor airflow beyond that level of obstruction from the terminal bronchiole to the alveoli, but also difficulty exhaling air that reaches the alveoli out of the bronchiole, and so air trapping, similar in fashion to what we'll see in just a moment with asthma. And so bronchiolitis, I think just the take-home message is if it impacts the bronchioles and causes severe obstruction of airflow. Many differentials that you may consider when faced with the young child with bronchiolitis, but bronchiolitis is so common it needs to be at the top of your list here. But other things you may consider: asthma or reactive airway disease. We often coin this disease for asthmatics who are under the age of 2 years. Whether or not that's an appropriate distinction, I think it's up for debate, but we won't belabor that point. Pneumonia from bacteria, chronic lung disease, particularly the ex-preemies who have made it out of the NICU and into the world. Foreign body aspiration, very common in the world of pediatrics and older infants and small toddlers who are starting to become more mobile and explore their world and putting new things into their mouth. GERD or dysphagia leading to aspiration, congenital heart disease or heart failure. We see mimickers of bronchiolitis at least a couple of times a year. They make it through the emergency department and onto the floor for a couple of days, and everyone is anchored on this diagnosis of bronchiolitis, and they aren't getting better. They aren't following the normal pathway. And then we find out that they're actually in heart failure, or they have a congenital heart lesion that was missed. And then other things, particularly some congenital anomalies that should be on your list, but farther down, include vascular rings, bronchomalacia, or other lesser common anatomical anomalies. Treatments, as with croup, it's caused by a virus, so treatment really is supportive in the tincture of time, highlighting the importance of hydration and nutritional status. Frequent suctioning. Remember, we talked about infants being preferential nasal breathers, and so if you can suction their nose, it's going to help their work of breathing because they really prefer to breathe through the nares rather than the mouth. Chest physiotherapy, which in the hospital will do this. That's really just kind of hitting on the chest in such a way to help kind of mobilize mucus, and so that it's easier for the child to cough up those secretions. Supplemental oxygen for the hypoxic child. As with croup, we talked about alleviating work of breathing with other modes of respiratory support. So high flow nasal cannula, non-invasive mechanical ventilation like CPAP or BiPAP, or intubation for mechanical ventilation. Some medications really that will be talked about in whether they're appropriate in the world of bronchiolitis. Really, the answer is there's not any great treatments, and the data really doesn't support any particular treatment for bronchiolitis. There are things that we will try, particularly in the child who is in severe respiratory distress on the verge of impending respiratory failure. Some things that we will try. So inhaled beta-2 agonists for bronchodilation, inhaled hypertonic saline to help mobilize secretions to clear the airway of secretions and mucus. Steroids, wouldn't generally recommend this, but you may consider it in the ex-premature child with known chronic lung disease at prematurity. Antibiotics, not generally in the patient who has managed to not need endotracheal intubation, but there was a study done some years ago on intubated patients with bronchiolitis, and it showed that up to 40% of them had a bacterial superinfection. And so the sickest of the sick, in other words, for the child with bronchiolitis, the sickest of the sick, they end up intubated, and it's reasonable to cover them for a bacterial superinfection while you await the results of the lower respiratory culture that you would send on intubation. An antiviral known as ribavirin. Some studies have been done on this. Really no evidence to suggest that it helps in acute bronchiolitis. Things that you can prevent, I think some common sense measures, but the one I want you to remember from this slide is at the bottom here. Synagis is a monoclonal antibody against RSV that special populations within the pediatric world will receive. We won't belabor that point, but it is an option for children who have certain risk factors like the ones we talked about a couple of slides ago. It does seem that children, particularly with RSV, at a young age, do have a higher propensity to develop asthma later in life. So that's an important association worth mentioning here. Finally, I want to talk about pediatric asthma. It's a very common disease entity in my world. You'll notice that the other three disease states that I have focused on for this talk are all infectious in origin. Asthma is not. Asthma is a disease of airway hyperresponsiveness and inflammation. It may be triggered, an acute asthma exacerbation may be triggered by an infectious disease, but it's not caused by an infectious disease entity. The pathophysiology of asthma is threefold. There's bronchoconstriction of the medium-sized airways. There's inflammation at the level of those airways, and then mucus and secretions. All of these result in obstruction of airflow. Not only of obstruction of airflow in, but once air has has moved beyond that level of obstruction, it gets trapped there in the distal airways and the alveoli. So you get air trapping and hyperexpansion of those airways. Kind of going back to some of the epidemiology here, we talked about how common it is. It affects nearly 10% of children. 80% of those will present before age 5. And then we see certain populations seem to be more prone to asthma exacerbations than others, particularly the African American Hispanic populations tend to have a higher rate of asthma exacerbations than other groups. And finally, on this slide, I just want to hit home the point that asthma is, particularly an asthma exacerbation, which we'll talk about in the next slide, is typically triggered by something. And there are some common triggers here that I want you to keep in the back of your mind. So a viral upper respiratory infection, common trigger, secondhand smoke from mom, dad, grandma, grandpa who smoke around the child, changes in the season, particularly when the season is changing from fall to winter or from winter to spring. Seems to be a higher incidence of asthma exacerbation during those times of the year. Allergens such as seasonal allergies, pet dander, dust mites, those types of things can trigger asthma exacerbations. Cold weather, certainly, and then exercise can also be a trigger for asthma. This is just an illustration that I borrowed from learnpicu.com to sort of put into a picture form what we talked about, the three-tier the three components of the pathophysiologic basis of asthma. The clinical presentation of asthma, so it may be acute or it may be more of a chronic picture. I work, of course, in the hospital, and so I live in the world of acute asthma exacerbations when I'm presented with a child who has asthma. So this is an acute, abrupt onset of shortness of breath, wheezing, chest tightness. Older children may actually tell you that their chest feels tight, and then coughing fits. Contrast this with a child who has chronic asthma. Signs, symptoms of that may be frequent coughing at nighttime, shortness of breath when they exercise, needing to use their rescue alveolar inhaler frequently, a sign that their asthma is not adequately controlled, or frequent exacerbations requiring ED or hospital admissions. That may be a sign that chronically their asthma is not well controlled. Asthma is a clinical diagnosis. Spirometry, particularly in younger children, is very difficult to attain. And so we use our clinical signs and symptoms to help guide us to the diagnosis. Things that we'll look for, of course, improvement in symptoms of cough and wheezing and shortness of breath when a bronchodilator has been introduced, such as albuterol. Other clues, the atopic triad is a classic question that comes up on your boards and in real life, truly, when considering an asthma diagnosis. And so that triad includes eczema, seasonal allergies, and asthma. And then, of course, a family history may be a clue too, that the child that you're dealing with who was wheezing and in respiratory distress may have asthma, if their mom, dad, brother, sister also has a history of asthma. Other diagnoses to consider: foreign body aspiration, bronchiolitis, anaphylaxis. All right, well, now we get to the clinical vignettes part. If you were in the live lecture and time got cut off, as I suspected it may, hopefully you'll have time to review this video and go through this section. I think this is probably the most helpful part of my talk. So let's jump into it and look at some clinical vignettes. So my disclaimer here to this question is this is not a disease that I covered in this talk, but I wanted to present you with it because A, it involves the upper respiratory tract, and B, I do think it is relatively high yield for your board exams, particularly step 1 and step 2. Let me flip over to my page and we'll get started. Okay. So this patient is a 17-year-old female presenting to the emergency department with toothache, on the left side of the face, times 7 days, along with progressive pain and swelling. She has known type 1 diabetes and is on an insulin management plan by her endocrinologist. However, mom admits that the child has been somewhat rebellious and obstinate about taking her insulin, and lately the mother is having trouble affording the insulin. So the child's recently missed many doses of her insulin. In the emergency department, vital signs show normal blood pressure for age, heart rate elevated 126, respiratory rate elevated 24, temp normal at 98. On the exam, you see the photos here on the left side on hospital day 1. When you're looking into the naders, you also notice a black eschar on the nasal terminate. On initial point of care labs in the emergency department, your team grabs a random blood glucose and it's elevated at 425. So, question: what is the most likely organism causing this illness? Staph, Haemophilus type B, strep pneumo, or Rhizopus mucormycosis. This is an example of mucormycosis from fungal infection such as Rhizopus. This is something that you need to kind of keep in the back of your minds for boards or later down the line. If you're working in hospital medicine, you may encounter this in the emergency department or on the floor. It may occur in patients with type 1 diabetes that's poorly controlled. It may also occur commonly, and this answers the question in box 2 here, may also occur commonly in patients who are immunosuppressed with diseases like leukemia or lymphoma, particularly if they're undergoing chemotherapy and their white blood cell count are low, such as their neutrophil, if their neutrophil counts are low. So this is a sinusitis with extension into orbital cellulitis caused by the fungus Rhizopus. All right, back to one that we did talk about in this lecture. An 18-month-old female presenting to the peds emergency department with respiratory distress. Per her parents, she's had 3 days of fever, up to 102. She's had increased work of breathing and stridor. She was seen by her pediatrician on the first day of illness, diagnosed with a viral URI. She's brought today because her parents notice a muffled voice. It appears to be worsening. They notice drooling and refusal to lay down. On your initial assessment, you're concerned that the child is anxious, quiet, ill-appearing. The child is sitting, leaning forward with her hands outstretched on the bed. When you approach her, she attempts to cry, but turns blue and becomes apneic. On review of the past medical history, the parents state that the child is unvaccinated. So question 1, what is the most likely cause of this illness? Asthma exacerbation, viral croup, foreign body aspiration, or bacterial epiglottitis? The answer to this one, of course, is bacterial epiglottitis. I think based on the physical exam finding of stridor, you can rule out asthma exacerbation. A viral croup we talked about is generally not toxic in appearance like this, and so we can put that one farther on our differential. Then foreign body aspiration. Foreign body aspiration typically is more acute in nature, and so it goes The story typically goes that the child was perfectly well until the parents found them and they were in imminent respiratory distress or failure, really at the drop of a dime. Um, Bacterial epiglottitis has a little bit more of a prodrome as this child did. So that is the correct answer. Question number 2, what is the most likely cause of this illness in terms of organism? Moraxella, Haemophilus influenza type B, strep pneumo, or Bordetella pertussis. The correct answer here is Haemophilus influenza type B. Case 3, 10-month-old infant, born at term, no significant past medical history, presents to the emergency department with 2 to 3 days of congestion, rhinorrhea, now with fever of 103 degrees Fahrenheit and increased work of breathing. On physical exam, you observe an ill-appearing child who is tachypnic, who's grunting, has diffuse bilateral wheezing and inspiratory crackles. Oxygen saturations are 90% on room air. What is the most likely cause of this illness? Asthma, acute bronchiolitis, viral croup, or foreign body aspiration. And so this one, a couple of things. Notice the patient's age. Remember, we talked about the bronchiolitis affecting infants and toddlers less than 2 years of age. Notice the lower respiratory disease with crackles and wheezing. So that should, and then the diffuse bilateral nature of it, that should rule out several of these for you. So viral croup is an upper respiratory tract disease. We can rule that out. Foreign body aspiration would be a focal unilateral finding, and so we can rule that one out. Asthma exacerbation. This child, it's certainly possible, but it's uncommon at a 10-month-old. Much more common would be acute bronchiolitis. Plus, this child has the viral symptoms of cough, congestion, fever that support that diagnosis. And so the correct answer here is acute bronchiolitis. What intervention or interventions should you consider at this time? Remember, the treatment for this is supportive, and so the tincture of time is the biggest treatment here. But this child clearly is going to need hospital admission. That's number one. There are some things that you may try to help mobilize secretions or clear their airway of secretions. So, suctioning at the nares may help. It may be worth, since this child is so ill appearing, it may be worth trialing albuterol, knowing that there's a very small percentage of children with acute bronchiolitis who will actually respond, but some of them will. So it may be worth trialing in this situation. Hypertonic saline may be used as a nebulizer to help mobilize secretions. And then, of course, supplying supplemental oxygen to help the hypoxemia in this child's case. Case number 4, 18-month-old male, otherwise healthy, presenting to the Peds ED, with acute onset respiratory distress while playing in the front yard. He was well prior to today. On exam, you note wheezing over the left lung field with decreased breath sounds on the left compared to the right. What is the most likely cause of this illness? Asthma, bronchiolitis, viral croup, or foreign body aspiration? I want to give credit on the prior slide before I answer this. I want to give credit on the prior slide. The imaging was courtesy of Dr. Luke Donahue, and this case was published on radiopedia.org. The bronchiolitis case from the prior slide. This one I want to make sure and credit Dr. Jeremy Jones, also published on radiopedia.org. And now that you've had time to think about it, delayed it enough, the answer to this question is foreign body aspiration. So a couple of clues to this diagnosis. The onset was very abrupt, very acute. The child went from being well to being very ill quickly. So you miss those viral prodrome type symptoms that you would expect to see in an illness like croup or bronchiolitis. So we're going to eliminate those two choices. Asthma exacerbation would be unlikely in an 18-month-old. It is possible, certainly. So you may argue to yourself, there must have been some sort of trigger, like a viral, like an allergen that triggered this. I think that would be a reasonable train of thought. But then you go to the X-ray, and the X-ray is really what gives this away. Looking at the x-ray here, the one on the left side, you notice that the left lung field is more hyperexpanded than the right. So that led this diagnostician to wisely pursue a left lateral decubitus film. And then if you'll look closely there, see if you can follow my mouse on the screen, you'll notice a foreign body in the left upper lobe of the lung. And so foreign body aspiration is the correct answer in this case. And in this case, courtesy of Dr. Jeremy Jones, this was actually, oh goodness, I thought it was in here. It was actually I believe it was a piece of gravel that the child aspirated. So pretty interesting. But notice the hyperexpansion of the left lung field, and then a left lateral decubitus was performed. And instead of that dependent downward facing lung collapsing as it typically would do in a healthy patient, it's still hyperexpanded, and the foreign body really declares itself there on that film. It's very obvious to see. Again, that was a disease that we didn't talk about in this part of the discussion. But I wanted to give you this clinical vignette because I do think that it's worth knowing, and it's also high yield for your exams. Finally, case 5. Let's read through this one. A 2.5-year-old female, previously healthy, presenting to the peds emergency department with 3 days of rhinorrhea, congestion, and a quote barky cough for the parents. Tonight, she's developed fever to 101. She's fussy. She has noisy breathing. When she's calm, the noisy breathing resolves. On exam, the child's fussy and exhibits stridor. O2 sats are 100%. You observe suprasternal retractions. Once calm and consoled by mom, the stridor and the retractions resolve. What is the most likely cause of this illness? Asthma, acute bronchiolitis, viral croup, or foreign body aspiration. And as I provide some time for you to think through this case, I want to give credit to Dr. Michael Sargent, who published this case on radiopedia.org and is the person to thank for this lovely image on the right. All right, so now that I've stalled enough, what is the correct answer here? Of course, it's viral croup. So a couple of clues to the diagnosis, many clues, in fact. The child is stridorous, and so that should eliminate a lower airway disease like asthma exacerbation or bronchiolitis, which you would typically expect to hear a finding, of lower respiratory obstruction, such as wheezing and asthma or bronchiolitis, or crackles, which you can also hear in bronchiolitis. We can rule those two out. Then foreign body aspiration. You can't have a foreign body that obstructs at a higher level in the airway that doesn't make it all the way to the lungs, the left or right main stem bronchus, and that can cause stridor. This child has clues of a viral prodrome with a few days of rhinorrhea, congestion, barky cough. Again, that kind of should clue you to thinking about croup. And then the other thing that really gives this away and moves you away from the diagnosis of foreign body aspiration is that the child looks better when calmed and consoled by mom. If this is a foreign body sitting somewhere in the upper airway, changing positions and calming a child won't result in alleviation of the upper airway symptoms. And then finally, looking at the X-ray, which is conveniently provided for you here, you do see the classic steeple sign of the trachea that you can see here on this NUC film. So the answer is viral croup. Finally, what medical treatment should you consider? Here, I just wanted you to consider the use of dexamethasone. That's a therapy that you can give to the child and then send them home, whether you're working in the clinic, an urgent care, or emergency department. You can give them the dexamethasone. You can observe them for some time, and then you can send them home safely as long as they continue to look well when they're calm. It may help, in the hours and days to come with upper airway swelling and potentially prevent, need for a hospital admission. However, if a stridor develops while the child is calm and at rest, what additional medical treatment should you consider? What I would say here is if they're stridulous, stridorous, at rest and calm. If you're in a clinic setting, you should consider sending this child to an emergency department. And then from there in the emergency department, would consider trialing racemic epinephrine, racemic epinephrine, which is an inhaled vasoconstrictor that's going to vasoconstrict the vessels here in this upper airway and help reduce edema in that portion of the airway. All right, that brings us to the conclusion of the talk. Again, my name is Jeremy Seitz. I work in the pediatric ICU. My unashamed plug for you is that I think the pediatric ICU is the most exciting place in the hospital, and I highly encourage any and all of you guys to come rotate with us. So reach out to me if you're interested. Would love to have you guys join us sometime in the next couple of years. If you have any questions about the presentation, the materials, or anything else related to pediatric respiratory disease or pediatric critical care, please feel free to reach out. Want to make myself very accessible to you guys. I appreciate everybody listening. Hope this was a helpful lecture and informative and enjoyable. Until next time, thanks.